Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Okay, so imagine your body has this built-in emergency rescue crew.
Right, like a really intense plumbing crew.
Exactly. And its entire job is to save your life if you start bleeding out or if your blood pressure just suddenly bottoms out.
Which is great in an emergency.
Oh, for sure. This crew is fast, it's powerful, and it's incredibly effective at keeping blood flowing to your brain and your vital organs. But what happens when that exact same rescue crew gets confused, refuses to clock out, and starts literally tearing down the walls of your own heart?
That is when things get really dangerous.
Yeah. So today, we're doing a deep dive into the drugs that act on the Renin-Angiotensin-Aldosterone system, or the RAAS.
The RAAS, yeah.
And for the college nursing student listening right now, consider this your custom-tailored last-minute lecture. We are unpacking Chapter 47 of your pharmacology text.
Literally translating all that dense drug info into plain English.
Right. Getting into the tight cause and effect clinical reasoning that you need to safely administer these medications right at the bedside.
Because to safely administer any of these 4 drug families, the ACE inhibitors, the ARBs, direct renin inhibitors, and aldosterone antagonists, you really have to deeply understand that natural rescue crew first.
You have to know what you're blocking.
Exactly. You cannot understand how the drugs block the system until you trace the actual biochemistry of the system itself.
Well, let's trace it. Let's trace that biochemistry. The chemical family tree here really centers around the angiotensins, right?
Yeah, that's the core of it.
You've got angiotensin II, which your text notes has very, very weak biologic activity.
Almost none, really.
Right. And there's angiotensin III, which has, moderate activity.
Sure.
But the undisputed star player, the one driving this entire rescue operation and causing most of the damage, is angiotensin II.
Right, angiotensin II. And it has a dual role that's basically designed to rapidly elevate blood pressure.
Okay, how does it do it?
Well, first, it causes profound vasoconstriction. It powerfully squeezes the arteriole.
That clamps them down.
Exactly. Which instantly increases the resistance in your blood vessels, and that spikes the pressure.
Right, like putting your thumb over a garden hose.
Perfect analogy. And second, it travels down to the adrenal cortex and triggers the release of another hormone called aldosterone.
Okay, but we really cannot ignore the third, much more insidious action of angiotensin II here.
Yeah.
Because it's not just a chemical that squeezes pipes, right? It actually alters the physical structure of the cardiovascular system.
Yes, the structural remodeling. This is so important.
Right, like in conditions where the system is chronically activated, so we're talking long-term hypertension, heart failure, or, right after a myocardial infarction, angiotensin II causes the heart muscle to hypertrophy.
It grows abnormally large and thick.
Yeah, and it also causes fibrosis. It literally lays down this stiff scar tissue in the cardiac muscle and the blood vessels.
Which is terrible for heart function. And that brings us to aldosterone's role in all of this. Once angiotensin II tells the adrenal glands to release it, aldosterone travels down to the kidneys. And its main job is to retain sodium and water. It pulls them right back into the bloodstream, which dramatically increases your blood volume and your pressure.
Because water follows sodium.
Exactly. But to do this, it has to trade something. So it forces the body to excrete potassium and hydrogen.
Ah, okay.
And crucially, just like angiotensin II, high levels of aldosterone cause that exact same dangerous cardiovascular remodeling and fibrosis.
Man, so they are both just wrecking the heart long term.
Yeah.
Okay, so tracing the actual cascade, right? Let's say a patient's blood pressure drops. The kidney senses a drop in pressure and releases an enzyme called renin into the blood.
Right.
Renin just floats around until it finds this protein called angiotensinogen, and it cleaves off a little piece to create angiotensin I.
Yeah.
And this is the rate-limiting step, right? It's the slowest part of the whole process.
Right, it sets the pace.
But then angiotensin-converting enzyme, or ACE, swoops in, grabs that really weak angiotensin I, and almost instantly converts it into the powerful blood pressure-spiking angiotensin II.
And boom, the system does its job. Blood pressure is restored. Evolutionarily, this is a brilliant mechanism for acute survival.
Right, if a bear attacks you and you're hemorrhaging.
Exactly. If you are bleeding out, the RAAS keeps you alive. But the clinical problem we face today is chronic activation. When a patient has long-term hypertension or heart failure, the system just runs constantly.
It never clocks out.
Never. And that drives that long-term cardiovascular pathology.
Okay, so Knowing that the ACE enzyme is the actual factory producing this destructive angiotensin II, the logical first step is to just shut down the factory.
Right. Cut it off at the source.
Which is our first family of drugs.
Right.
The ACE inhibitors. But when I look at the mechanism in the text, it's not as simple as just stopping one chemical, because this enzyme actually moonlights. Like, it has two jobs.
Yeah, that is a really crucial concept for exams. Angiotensin-converting enzyme, ACE, and another enzyme called kinase II are literally the exact same enzyme.
But they're the same thing?
The exact same thing. We just call it ACE when it's converting angiotensin II into angiotensin II, but we call it kinase II when it's doing its other job, which is breaking down a hormone called bradykinin.
Oh, wow. Okay, so an ACE inhibitor is like firing a worker who is doing two completely different jobs for the company.
That's a great way to think about it.
You give the drug, and two things happen simultaneously. First, you decrease angiotensin II, which is the main goal. The arterioles dilate, blood volume drops, and amazingly, it can actually reverse that dangerous cardiac remodeling we just talked about.
It physically heals the heart. But the second thing that happens is you increase bradykinin.
Right, because kinase II is fired.
Exactly.
Right.
Because you've inhibited kinase II, it can no longer break bradykinin down. So bradykinin just builds up in the body, and this provides some extra vasodilation, which is helpful for blood pressure, but
there's a catch.
A big catch. This buildup is the direct cause of some very specific, really frustrating adverse effects.
Right, which we'll get to in a second. But before we get to the side effects, I mean, these drugs are absolute workhorses in the hospital.
Well, definitely. They're
approved for hypertension, heart failure, acute MI, and just lowering overall cardiovascular risk. Like, the HOPE trial proved that the ACE inhibitor ramipril significantly reduced the risk of heart attacks and strokes in high-risk patients.
Ramipril is fantastic for that.
But one specific use jumped out at me in Chapter 47, diabetic nephropathy. The text says ACE inhibitors protect the kidneys in diabetic patients. But how? How does just lowering systemic blood pressure specifically save the kidney's filtration system?
So to understand that, you have to look at the kidney's microscopic filter, the glomerulus.
Okay.
Think of the glomerulus as having an inflow pipe, the afferent arteriole, and an outflow pipe, which is the efferent arteriole.
Got it. Efferent in, efferent out.
Exactly. Normally, angiotensin II powerfully constricts that efferent outflow pipe.
The exit pipe.
Right, and if you pinch the exit of a filter, you create massive back pressure inside the filter itself.
Right, is forcing the fluid through the filter under incredibly high pressure.
Yes. And over time, especially in a diabetic patient whose blood vessels are already sort of compromised, that high filtration pressure physically damages the kidneys, and that leads to nephropathy.
Oh, that makes so much sense.
So when you give an ACE inhibitor, you remove the angiotensin II. That efferent outflow pipe relaxes and opens up. The back pressure inside the filter drops, the glomerular filtration pressure normalizes, and you slow down the progression of renal injury.
That is so cool.
It is. But note, however, that they only slow the progression once it has actually started. If a diabetic patient has zero signs of kidney damage yet, an ACE inhibitor will not provide primary prevention.
Wait, hold on. I need to push back here for a second because I'm looking at the adverse effects list. You just explained beautifully how ACE inhibitors protect the kidneys in diabetics.
Right.
But further down, it lists renal failure as a major life-threatening adverse effect of ACE inhibitors. I'm totally lost. Does it protect the kidney or does it destroy the kidney? Which is it?
I know, it sounds like a total contradiction, but the physiology explains it perfectly.
Okay, break it down.
ACE inhibitors are incredibly dangerous, like often absolutely contraindicated for patients with a specific condition called bilateral renal artery stenosis.
Bilateral renal artery stenosis, okay.
In these patients, the main arteries supplying blood to the kidneys are physically narrowed or blocked. The inflow pipe is choked off.
Oh, I see where this is going.
Yeah, because the inflow is choked, their kidneys completely rely on that severe angiotensin II back pressure just to push blood through the filter. They literally need the outflow pipe clamped shut tightly to maintain any basic filtration at all.
Wow.
So if you give that specific patient an ACE inhibitor, you relax the outflow pipe. With a blocked inflow and a wide open outflow, the pressure inside the filter drops to zero.
And kidney filtration just stops completely.
Exactly, putting them into acute renal failure.
That makes total sense. It's all about the pressure dynamics. Okay, let's run through the other critical nursing implications for ACE inhibitors, starting with the very first time you hand the patient the pill. First dose, hypotension.
Right. So when you administer that first dose, you are abruptly dropping the patient's angiotensin II levels. The blood vessels suddenly lose that squeezing tone and they dilate rapidly, causing blood pressure to just plummet.
So what's the nursing action there?
As the nurse, you must monitor the patient's blood pressure closely for 2 hours after the initial dose. And you should also anticipate that the provider will withdraw any diuretics the patient is taking, usually 2 to 3 days prior to starting the ACE inhibitor.
Just to prevent this severe compounded drop in fluid volume.
Exactly.
Next is the infamous ACE cough. It's this persistent, dry, hacking cough that basically doesn't respond to any cough medicine.
Right, and this brings us back to that moonlighting enzyme. That cough is directly caused by the buildup of bradykinin in the lungs.
Because kinase II is fired.
Exactly. It affects about 10% of patients, and it's actually the most common reason people just refuse to keep taking the medication.
Yeah, I'd hate that too. Then we have hyperkalemia. We know less angiotensin II means less aldosterone. And since aldosterone's job is to throw potassium out of the body, blocking it means the body holds on to potassium.
Yes. And the nursing takeaway here is all about patient education. You have to explicitly teach your patients to avoid potassium supplements.
Right.
And to never take potassium-sparing diuretics unless they are being really closely monitored by their provider.
We also have a major warning regarding pregnancy, right? ACE inhibitors are strongly contraindicated in the second and third trimesters.
Very strongly, because they cause severe fetal injury, including skull hypoplasia and irreversible renal failure in the fetus. And honestly, the current guidance is to avoid them early in pregnancy as well.
Okay, and the final, black box level warning is angioedema.
Yes, this is huge.
It's a rare but life-threatening swelling of the tongue, the glottis, lips, and pharynx. And just like the cough, this is triggered by that massive localized buildup of bradykinin, right?
Exactly. It increases capillary permeability so fluid just leaks into the tissues. If a patient reports swelling or difficulty swallowing, they need immediate emergency care, usually subcutaneous epinephrine.
Wow, okay.
And the absolute critical rule for you as a nurse, they must never be prescribed an ACE inhibitor again, ever.
Good to know. And for the pharmacology exam, keeping the pharmacokinetics straight is key.
Mm-hmm.
Nearly all ACE inhibitors are given orally, with one exception.
Right. And olaprolid.
And olaprolid is given IV for severe hypertension.
Exactly.
And most of them are prodrugs, meaning the liver has to convert them into their active form. Except for lisinopril, which is just active right out of the bottle.
Very common exam question, yeah.
And almost all of them require a dosage reduction in patients with kidney disease, with the exception of fascinopril.
Right. So you have a patient whose blood pressure is beautifully controlled on an ACE inhibitor, but they are absolutely miserable.
Like they have the cough.
Right. They are part of that 10% dealing with A247 hacking bradykinin cough. Or worse, maybe they had a mild angioedema reaction.
Yeah, that's scary.
But you can't just leave their hypertension or their heart failure untreated. So how do we bypass that bradykinin side effect without losing the cardiovascular protection?
Well, you change the locks on the doors.
Exactly.
That's the angiotensin II receptor blockers, or ARBs. Instead of shutting down the factory that makes angiotensin II, we just let the body make it. But we put super glue in the receptor locks on the blood vessels and tissues.
Right, so angiotensin II is floating around, but it can't bind to anything.
It's locked out. And crucially, because we aren't messing with the ACE enzyme at all, kinase II just keeps working. It keeps breaking down bradykinin.
Yes. And no bradykinin buildup means essentially zero risk of that hacking cough and a dramatically lower risk of angioedema.
Okay, looking at their applications, ARBs are approved for very similar indications, right?
Mm-hmm.
Hypertension, heart failure, specifically using valsartan and candesartan,
Mm-hmm.
and diabetic nephropathy using irbesartan and losartan. But there's an interesting piece of data regarding losartan. The text says it was shown to prevent stroke better than the beta blocker atenolol, even when both drugs lowered blood pressure by the exact same amount.
Yeah, that's a huge finding.
It proves the therapeutic benefit isn't just about lowering the physical numbers on a blood pressure cuff, right? It's about specifically blocking those destructive structural properties of angiotensin II.
Which begs the question, if ARBs don't cause the miserable cough and they block the exact same destructive chemical, why aren't they just the first choice for everyone?
Yeah, why are ACE inhibitors still the gold standard?
It purely comes down to the clinical data. ACE inhibitors have massive, decades-long gold standard studies proving beyond a shadow of a doubt that they reduce overall cardiovascular mortality.
They have the receipts.
They literally save lives, and we can prove it. The evidence for ARBs reducing mortality is solid, but it is simply not as strong or as comprehensive as the ACE inhibitor data yet.
Oh, okay.
Therefore, clinical guidelines dictate that ACE inhibitors are the preferred first-line choice. ARBs are reserved as the second choice for patients who absolutely cannot tolerate ACE inhibitors.
On it. And the adverse effects for ARBs basically mirror ACE inhibitors, just minus the bradykinin issues, right?
Pretty much. They still carry the risk of fetal harm. They will definitely still cause acute renal failure in patients with bilateral renal artery stenosis, but they do not cause clinically significant hyperkalemia the way ACE inhibitors do.
Okay, so we've stopped the enzyme that makes the chemical. We've blocked the receptor it binds to.
That's right.
But looking at this whole cascade, it kind of feels like we are constantly doing downstream cleanup.
Right.
Like, why don't we just shut off the faucet at the very beginning of the plumbing system?
Well, that is exactly what the direct renin inhibitors do.
Okay. And currently there is only one drug in this class, right?
Yep, aliskiren.
Aliskiren. It binds tightly and directly to the renin enzyme itself. By neutralizing renin, you stop that very first rate-limiting step where angiotensinogen is cleaved into angiotensinogen.
You're just stopping the whole cascade before it even starts.
Right. The entire RAAS cascade is suppressed from the top down. But, shutting it down at the source seems elegant, but its therapeutic uses are surprisingly limited in the text.
Yeah, they are. Aliskiren is currently approved only for hypertension. While it lowers blood pressure effectively, it completely lacks the proven mortality and clinical outcome benefits that make ACE inhibitors and ARBs so valuable in heart failure and post-MI care.
It just doesn't have the data.
Right.
And the major nursing implication for aliskiren really revolves around its pharmacokinetics. It has an incredibly low oral bioavailability, like only about 2.5% of the drug you swallow actually makes it into the bloodstream.
Which sounds crazy, right?
Yeah. How does a drug even work when 97% of it is lost?
Well, the dosing accounts for that massive loss. But the real danger for the nurse at the bedside is how fragile that 2.5% absorption actually is.
Okay, what do you mean?
If the patient takes aliskiren with a high-fat meal, say a cheeseburger or a really heavy breakfast, that tiny absorption rate plummets even further.
Oh, wow.
Yeah, the patient just won't absorb enough drug to control their blood pressure. So you have to teach the patient to take it at the exact same time every day relative to meals. For example, exactly 1 hour before dinner. Every single day.
Just to ensure consistent absorption.
Exactly.
And side effects for aliskiren include dose-dependent diarrhea, the same severe risk of fetal injury we talked about, and potential hyperkalemia, especially if the provider compounds the issue by combining it with an ACE inhibitor or an ARB.
Right. You have to be careful with combinations. So shutting off the faucet at the top with aliskiren doesn't give us the mortality benefits we want.
Right.
Let's look at the very bottom of the cascade then. Angiotensin II's partner in crime, aldosterone.
The final villain.
Yes. We know it causes fluid retention and cardiac fibrosis.
So we use aldosterone antagonists.
Mm-hmm.
The two drugs to know for the exam are allopurinol and spironolactone.
Right.
Their mechanism is pretty straightforward. They block aldosterone receptors in the kidney. This forces the excretion of sodium and water, reducing blood volume, and it causes the retention of potassium.
Exactly.
And importantly, by blocking the receptors right on the heart tissue, they actually halt that pathologic cardiovascular remodeling.
Which is huge. The clinical difference between those two drugs, though, really comes down to selectivity.
Selectivity.
Eplerenone is the newer drug, and it is highly selective. It only blocks aldosterone receptors.
Just a sniper.
Exactly. Spironolactone, on the other hand, is an older drug, and it is non-selective. It doesn't just block aldosterone. Its molecular structure is similar enough to other steroid hormones that it accidentally binds to and blocks glucocorticoid, progesterone, and androgen receptors.
Oh, man. And that lack of precision creates a whole host of uncomfortable endocrine side effects for patients taking spironolactone.
Yeah, it really does.
Because it's interfering with androgens and mimicking progesterone, male patients often develop gynecomastia, breast tissue enlargement, and impotence.
Right.
And female patients often experience menstrual irregularities and deep voice changes. But Eplerenone avoids almost all of those issues, right?
It does. But regardless of which one is used, the paramount safety risk here is hyperkalemia. We are intentionally blocking the hormone that excretes potassium. So potassium levels are absolutely going to rise.
And here is where patient education becomes basically a matter of life and death. Because if you have a patient with high blood pressure, they are often told to lower their sodium intake.
Right.
So what do? They go to the grocery store and they buy a salt substitute, thinking they're making a healthy choice.
It makes sense logically to them, but they don't realize that almost all commercial salt substitutes are made of pure potassium chloride.
Oh, wow.
Yeah. If a patient on an aldosterone antagonist uses a potassium-based salt substitute, their serum potassium can rapidly reach fatal heights, triggering lethal cardiac dysrhythmias.
That's terrifying.
It is. You must explicitly warn them against this. In fact, eplerenone is completely contraindicated if a patient's baseline serum potassium is already above 5.5 milliequivalents per liter.
Wow. Okay. And you also have to carefully review the patient's medication list for specific drug interactions with eplerenone, mainly CYP3A4 inhibitors.
Yes. CYP3A4 is an enzyme in the liver responsible for breaking down eplerenone.
Okay.
If the patient is taking a drug that inhibits that liver enzyme, like, say, the antifungal ketoconazole, the liver just can't clear the eplerenone.
Oh, so it creates a metabolic bottleneck.
Exactly. The levels of eplerenone in the blood can increase up to 5-fold, posing a massive toxicity risk.
Okay, we have covered a massive amount of pharmacology today. We traced the entire plumbing system from the liver to the kidneys to the lungs and back to the heart.
We covered a lot of ground.
Yeah, we fired the moonlighting ACE enzyme, we changed the ARB locks, we shut off the renin faucet, and we blocked the aldosterone fibrosis.
We really did. But before we wrap up, I want to leave you with a thought experiment that kind of challenges how we traditionally view this whole system.
Okay, I love these. Let's hear it.
We treat the RAAS like a systemic highway, right? Kidneys release renin into the blood, lungs release ACE into the blood. But recent research shows that individual tissues like the heart muscle itself or the walls of specific blood vessels can produce their own local angiotensin II.
Wait, really? Entirely independent of the main bloodstream?
Entirely independent of the systemic blood and the kidneys.
That is wild.
Yeah. So as you move forward in your nursing career, consider this. How much of severe cardiovascular disease is actually a localized tissue failure, like a local biochemical short circuit in the heart muscle itself, rather than just a systemic blood pressure problem?
Wow. That completely changes how you look at a failing heart.
It really does.
Well, to the nursing student listening, a massive thank you from the Last Minute Lecture team. You now know the mechanisms, the pressure dynamics, the drug interactions, and the whys behind Chapter 47.
You are going to do great.
You are fully prepped, and you are ready to absolutely crush your pharmacology exam. Good luck.